Welcome to this explainer. You know, if you're a medical coder or a healthcare provider, you already know the struggle. Reading CPT guidelines can literally feel like trying to decipher a dense legal textbook written in another language. It's complicated, the rules are incredibly rigid, and the stakes? Well, they're high. We're talking denied claims, lost revenue, and those dreaded audits nobody wants to deal with. But today, we're going to translate all of that. We're breaking down the complex rules of prolonged care so you can code confidently and actually capture the true value of your hard work. Okay, let's dive right into this and map out our path. First, we're going to establish the baseline of time coding. Second, we'll look at care without direct contact. Third, we'll shift over to clinical staff prolonged care. And finally, we'll wrap up by looking at some crucial exclusions and common errors you really need to avoid.
Starting off with Section 1, the baseline of time coding.
So think of your standard evaluation and management, or EMM, codes as the foundation of a house. You really can't build an extension on that house until the foundation is rock solid, right? Well, in the coding world, prolonged codes are our add-on extensions. Before we even look at them, we need to clearly establish what time actually means in the CPT guidelines. When we're coding based on time for an office or outpatient visit, time is defined as the total time on the date of the encounter. This is absolutely critical to remember. It includes both the face-to-face time with a patient or caregiver and the non-face-to-face time personally spent by the provider on that exact same day. That means preparing to see the patient, reviewing tests, and documenting clinical info in the health record all count toward this total.
But, just as important as what you can count is what you absolutely cannot count. Let's spotlight some common misconceptions right away by laying out exactly what activities cannot be bundled into your time calculations. The CPT guidelines are super clear here. You must not count time spent on travel. You cannot count general teaching that isn't specifically tied to managing that particular patient. And perhaps most importantly, you cannot count the performance of other services that are reported separately. Basically, if you're billing a distinct procedure code for a test interpretation, you can't double dip and count that same time towards your E&M or prolonged services total. Makes sense, right?
Let's move to Section 2 and see how this builds as we look at care without direct contact.
We just established that standard time is counted on the date of the encounter. But what happens when a provider has to do a massive amount of work for a patient on a completely different day? Take a look at this excerpt straight from the CPT manual. This outlines codes 99358 and 99359. These codes are specifically designed for prolonged evaluation and management services without direct patient contact. Imagine a scenario where a provider has to do an extensive, hours-long medical record review for a really complex patient, but they do this heavy lifting on a Tuesday, and the actual face-to-face visit doesn't even happen until Thursday. Because this work occurred on a date other than the face-to-face encounter, you can't bundle it into Thursday's visit time. And that is exactly where 99358 and 99359 step in to save the day.
Let's anchor on the specific time thresholds here, because time-based coding is pretty ruthless if you miss the minimums. Notice the starting line is exactly 30 minutes. If the provider spends, say, 29 minutes reviewing records on a non-encounter day, you cannot report it separately. There's no rounding up here, it's simply absorbed into the general care of the patient. However, the moment you hit that 30-minute mark, and up to 60 or even 74 minutes depending on the increment, you can confidently report 99358 once.
And that magic number, 30, is vital for the add-on code 99359 as well. You use 99359 for each additional 30 minutes beyond that first hour of prolonged service. But a quick heads up, the guidelines are incredibly strict here. Any prolonged service of less than 30 minutes, meaning if you don't hit at least 15 minutes beyond the first hour or final 30-minute block, is not reported separately. You really have to cross that halfway threshold of the next increment to earn the add-on code.
All right, Section 3, clinical staff prolonged care.
Up until now, we've been entirely focused on the provider's time. But what about your team? Imagine your clinical staff, your fantastic nurses or medical assistants, spending extensive face-to-face time with a patient on the day of an office visit. Maybe they're continuously monitoring someone who just had an adverse reaction in the clinic. For situations like this, the rulebook gives us codes 99415 and 99416. These are used to report the total duration of face-to-face time with a patient or caregiver spent specifically by clinical staff on a given date in an office or outpatient setting. Now, it's incredibly important to note here, while this is clinical staff time, the physician or other qualified healthcare professional must be present to provide direct supervision. Now, what's really interesting about this slide is how the threshold actually works. Unlike provider time, where we just look at the total clock time, 99415 requires a starting point that is 30 minutes beyond the typical clinical staff time for that primary EM service. So you literally have to check the CPT codebooks table for typical staff times, max that baseline out, and then go a full 30 minutes further just to report your very first unit of 99415. Then, once you've successfully documented and crossed that first prolonged hour with your clinical staff, you shift over to code 99416. This add-on code is used for each subsequent 30-minute block of clinical staff service. And just like we saw before, if the extra time is less than 15 minutes beyond that first hour, you don't get to bill 99416. This is why accuracy in time tracking by your clinical staff is absolutely paramount. Moving into our final stretch, Section 4, Crucial Exclusions and Errors. So the crucial point here is that any veteran coder will tell you CPT is defined just as much by what you are explicitly forbidden from doing. Do not mix these code families up. Let's cleanly contrast them so you never get confused. For 99358 and 99359, we are talking about provider time, non-face-to-face, on a different date. For 99415 and 99416, we are talking about clinical staff time, face-to-face, on the same date. Keeping this mental divide sharp will seriously solve half of your coding headaches. Let's adopt a bit of a cautionary tone here to walk through the specific parenthetical exclusions because these are guaranteed audit traps. For the provider codes 99358 and 99359, you absolutely cannot report these on the same date of service as a face-to-face EM visit. If the provider reviews records in the morning and then sees the patient in the afternoon, all of that time just bundles into the same day EM code. Furthermore, you cannot mix these codes with the other major prolonged service add-on codes 99417 or 99418. They are totally mutually exclusive. Finally, let's guide you step by step to a really common error, the facility billing trap. When you're looking at clinical staff prolonged care, step 1 is identifying your setting. Step 2 is verifying the clinical staff time. But step 3 is the real kicker. The CPT guidelines explicitly state that facilities may not report 99415 or 99416. These are strictly for office or other outpatient non-facility settings. Also, you can never report these clinical staff codes in conjunction with the primary provider prolonged code 99417. Oh, and speaking of strict exclusions, a quick bonus rule for providers. If a clinician is requested by another clinician for standby services, like an operative standby, waiting for a frozen section, or a high-risk delivery without direct patient contact, you use code 99360. But here's the catch. That code requires a strict full 30 minutes of standby time to be reportable, and you absolutely cannot report it if that standby time ends up turning into a procedure subject to a surgical package. So what does this all mean for you? The work you and your team do for complex patients is immensely valuable, both clinically and operationally. But if you don't master the specific dates, the exact time thresholds, and the strict parenthetical exclusions, you are either leaving hard-earned money on the table or walking right into a compliance audit. I want you to take a look at your current time tracking systems tomorrow and ask yourself, are we truly capturing all this complex work correctly without triggering those hidden exclusions? Don't forget to like, share, and subscribe to Decode Healthcare with Hershal.